Well, I guess we can get started. Antony Stately speaking to us. He's a clinical psychologist. He has a really long biography, and I've shortened it down a lot here. After getting a Ph.D. from Alliant International University in California, he practiced in Los Angeles, the University of Washington in Seattle, as well as elsewhere on the West Coast. He also served as a consultant and advisor to numerous NGOs, delivering health services to tribal and indigenous communities nationally and internationally, including the U.S.-Mexico Border Health Association. And I told him that some of us had just been at the border. He's a member of the Oneida band of the Ojibwe Nation. Is that the correct way to say that? I hope, sort of. Oh, both. Okay. And is currently the executive officer and president of the Native American Community Clinic, NACC, in South Minneapolis, about 2 miles from here. But during conversations arranging this visit, I learned 2 Ojibwe words. So I'm going to show off now and say, and you can join me. Buju means hello. So we can say Buju to Dr. Stately and welcome. So go forth.
Awesome. Thank you so much, Myra. Sorry, I'm closing all these things that'll beep at me while I'm talking. So, and that's my diabetes thing telling me that I'm shutting off the alarm. So it's okay. Good morning. I'm Antony Stately. And I was telling Myra, thank you so much for the introduction. Miigwech, that's another Ojibwe word she's going to teach you later. I was telling Myra that I have some affinity to the church because my first apartment after I moved out of my mother's house, I born and raised in South Minneapolis here, until and lived in Minneapolis till I was 23. And then my first apartment was right across the street behind the Park Nicollet Clinic in that brownstone on the first floor. So my apartment windows, my bedroom, and everything looked out over that parking lot. So I got to see people come and do all kinds of really crazy stuff in the parking lot late at night. And then also, got to watch people come and go for the early morning appointments before I went off to work, which was always exciting. But I also got clean and sober in when I was very young, around 22 years old. And I used to come to AA meetings here in the church. It was like one of my places of refuge. The Lambda Center up the street was another place I went to meetings at, but this was like, I had a regular meeting that I came here. It was really convenient, right across the street, and as my sponsor liked to say at that point in time in my life, and I was kind of an unruly child. Actually, some people say I'm still an unruly adult. He would say, like, there's no excuse not to go to a meeting. It's right across the street from your house. And so I was like, okay, yeah, I'll just do that. So anyway, the Native American Community Clinic, I've been this executive officer of NACC for just over 6 years now. I'm the first Native executive officer and the first Native person in leadership. We just celebrated our 20th anniversary on February 11th, I think. 11th, yeah. So that was really exciting. 20 years of, is a big milestone for us, really exciting. I tell everybody we're going to have a big party in the summer and we're going to call it our almost legal party. So, not quite there yet, but almost legal. Anyway, one thing you'll notice about me is I like tell a lot of jokes. I think it's a Native thing. We're known for our humor, I think. So who we are, this is our mission. Our mission is to promote health and wellness of mind, body, and spirit among Native American families. Our values, we honor tradition and health. We provide high quality care regardless of people's ability to pay. Be a good relative to all. That's a fundamental, I think, universal value and principle of almost every indigenous culture I know. I met a lot of people and from all kinds of different cultures that are indigenous. And I think we have this idea that like when we come to we come to the earth from the creator or God, or whatever your conception is of that, that benevolent being that that animates us and also sort of kind of sets us on our path. But when we come to the earth as spirits, we're given a set of original instructions, is what we call them. And original instructions are kind of like your moral compass and your values and the way that you operate while you're here. And we also believe that we come here as Wakanija, like these little spirits, babies. We're human, we're perfect spirits. And our biggest task is to learn how to be human, which challenges all of us, right? And that's because we're spirits really, and we're in body form right now and human form, and we don't have a lot of experience being humans. We only get the experience that we're here. And then we go back and we're spirits again, and kind of a thing, or our spirit returns. So that's a really fundamental principle that I kind of like talked a lot about when I first got to the clinic 6 years ago, because I happen to believe, so I made this rule, not rule, I made a recommendation. People call it a rule, but it's really a recommendation. But people, if an executive officer speaks, people think like, oh, I got to do that. This is a recommendation. I asked the question, I said, I wonder what would happen to our care model if we start asking, referring to the people that come through the doors and ask us to provide a service to them, if we called them relatives rather than patients. Like, I wonder how we might behave differently towards them and how that might change the way we think about their care, and how we might go about that approach. And, it's really been a fundamental sort of shift, I think, in our psychology and our understanding of the way we deliver care and do care. We're much more sort of embedded, I think, in the community. As a community health center, that's a really fundamental thing. So I'll talk a little bit more about that. But we honor diversity and inclusion. Decrease health disparities among American Indian families is a really important fundamental part of our mission. Native children and adults and families have some of the worst health care in the state, if not across the United States. And so, we're a little tiny clinic, not as tiny as when I first got there. Actually, we more than tripled in size in terms of staff and budget, but we're a little tiny clinic trying to do our part. And so I think that's just important to know about us. We're a federally qualified healthcare center too, and we're located in South Minneapolis along Franklin Avenue's American Indian Culture Corridor. And the American Indian Culture Corridor is an established entity. It's a thing that is kind of recognized by the city and the county in Minneapolis. It's sort of the center of American Indian commerce, social services, healthcare, a bunch of things. It's kind of like, and the history there is that South Minneapolis was a relocation site when the federal government passed a federal policy in 1952 called the American Indian Relocation Act. A lot of natives from the surrounding reservations were incentivized to move to Minneapolis. And of course, we're social people, we're collective people, we're more focused on group identity. So we kind of clustered in this one area. And it's an area where I grew up and I know really well. I know the history of it really well. Our relatives, 75 to 80% of our population that we serve is Native American. The other 15% is made up of African American, Latino, small percentage of Latino, because we don't have a lot of staff that speak Spanish. So we use interpreters, but we don't see a lot of them. They go to down the street to Clues and Unidas and a few other places. We see some East African folks, of course, white folk, and we have a fair number of people who I think would be identify as GLBT or Two-Spirit. So we have about 3 or 4% of our patient population is, I think actually it's closer to 7%. So 7% of our population would be considered GLBT or Two-Spirit. You can see that we primarily, I'm assuming that's the pointer, but we are, because we're a federally qualified healthcare center, we're considered part of the safety net healthcare structure that undergirds like, the bigger hospital systems. Most people go to a primary care doctor. They don't usually go to the hospital to consume their services, or big health systems just consume their healthcare services. They are across the United States, community health centers and federally qualified healthcare centers specifically, they take care of about 1/3 of the population of the country, which is, I don't think a lot of people know that. So one of the reasons why it's so incredibly fundamental, we're considered part of the primary care system. So I mentioned that because there is lots of challenges right now on the, in fact, many of my colleagues were on the Hill last week testifying before Congress about the importance of community health centers and the role that we play in the fundamental foundation of building blocks of health. Because there is a move in the House to sort of like, not pass the community health center, the bill that funds community health centers. So really important piece of legislation to sort of watch. And if you are at all sort of like politically motivated, or, you pay attention to those things, like watch that bill, because it will really hurt community health centers across the United States, not just ours, but across the United States, if that bill does not get passed. So why we started, these are the things that we sort of saw in our community when we first started, and these challenges have gotten better in some areas, but in recent years they've gotten worse. So we see we have NACC. My clinic is part of a federally qualified healthcare network of 10 FQHCs in the cities of Minneapolis and St. Paul. So there's 10 of us that belong to this organization called FUN. NACC, we collect data on our patients and their various chronic diseases and a number of other conditions. And we sort of like use those to sort of kind of see collectively how we're doing across the spectrum of the 10 FQHCs and managing the safety net services of our patients. It gives us all kinds of really important information. But NACC, compared to its 9 sisters that serve the other parts of the 2 cities, among them, we have the highest relative risk scores. That means our patients that we see are significantly more sick or ill and have many more complications and many more social determinants of health that impact their ability to actually solve their health conditions. We have some of the highest avoidable emergency room visits, some of the highest rates of chemical dependency and mental health issues, and high prevalence of these specific chronic conditions, which are very life-threatening and debilitating. Sepsis, diabetes. Interestingly enough, and if any of you have ever been hospitalized, but lots of people go into the hospital with and need procedures done. Sometimes there are procedures that can be done in a really well managed clinic, or a clinic that has the capacity to do those services, like small surgeries or outpatient surgeries, we would call them. But they go in the hospital for those things if they don't have access to that, and a lot of members in our community don't have access to that, so they have to go to large health systems. It is not too untypical for you to come out of a hospital after having surgery and having, infections that then turn into sepsis and aren't managed well. And so part of that is like, that's one of the drivers of that problem there, because we don't have a health system that can do outpatient surgeries for a clinic for our people. So we have the poorest health outcomes, and the lack of access and resources and those kinds of things are really fundamental. That you might not know this, but natives have represent about 1/4 of the population of the state that is houseless, so homeless. I say houseless because, our relationship to the land and the space and place is our home. So we do have a home, but we don't have structures to live in. A lot of our families don't. So the newest challenge that was beset us, right, would be the pandemic, which kind of, was a global wide thing. Well, one of the challenges that we had with COVID-19 in our community and in our clinic specifically as well was that we were at the very early rate, we were seeing significantly highly or disproportionately high rates of COVID-19 infection, hospitalizations, and death. The rate of infection, hospitalization, and death for Native people specifically in the state of Minnesota and a number of other areas in the United States were 2 and 3 and 4 times higher than other populations. And that is a direct sort of like relationship between things like if I have insurance, whether I have insurance or not, people generally are likely to not go to get healthcare if they don't have health insurance. They don't want to get saddled with a big bill, right? There's all kinds of challenges with that. Access to barriers. So one of the things we did, we rolled out a vaccine and communication plan when the vaccines were ready. We made them available. We were one of the few people. So when the vaccines first came out, the governor said, like, we're going to prioritize these communities that have highest rates of infection. So elderly people generally got it right away. In fact, actually, nobody was eligible for it unless they were 65 and above when it first came out, right? And then he pivoted to a bunch. They added additional groups of people or populations, and Native people became one of the highest ranking populations because of that condition we were seeing, where there were significantly higher rates of infection, hospitalization, and death in those first few months or first year probably. And in my role as the executive officer, I was on an advisory board with the governor's cabinet, and these are one of the things I was bringing to their attention. I said, like, we're such a small population. To lose, 5, 10 people in our population, especially if they're elders, there are language keepers, our cultural knowledge keepers, our wisdom keepers, those kinds of things. That was a big hit to our community. So I was like, we need to get these vaccines into our community as quickly as possible. But, as you all recall, probably there was a lot of misinformation, lots of questions, lots of concerns. People were scared. There's all kinds of things that. What we did was when we got the vaccines, we spoke to some elders that we had hired in our clinic the year before to be our elders in residence, help us with cultural and traditional healing work and those kinds of things. We brought those folks to the table, and we said, how should we do this? So before we just said, hey, we're vaccinating people. They said, well, let's do this because people are really anxious and scared. Let's have a ceremony where we pray over the vaccines and we ask Creator to make these things helpful to us and harmful, not harmful, but helpful. And we talked about that process, and we went through the intentional process of making sure that the elders in our community and the rest of the community, their children and their grandchildren felt comfortable approaching the vaccines because we had offered prayers as well. So like you, we believe solidly in the power of prayer. I think I don't have time to go into it today, but I pretty much, when I don't know what else I'm going to do in my life, or when I'm challenged by a big thing at work, which seems daily, if not weekly, it seems daily sometimes. If I don't know what I'm going to do, I'll light a bowl of smudge and I'll put out some tobacco and I'll just ask Creator, we have this word in Dakota, and actually I'm married to a Dakota man and my children are Dakota, so I speak way more Dakota than I do Ojibwe. But there's a word in Dakota called that's called omakia. And omakia means to pray or to cry for help. So if I'm struggling, I always say omakia, Creator, and I'll call out to him or her. I happen to think the Creator's a female because all things are created by women. Life comes from women, right? So, and probably they don't have a gender probably, actually, quite frankly. But the point is that in my conceptualization, I think of her as this big benevolent mother, takes care of everybody. And I'll say, help me, Omaki, I don't, help me find my path. And every single thing that I have ever done in my life that has been meaningful or important or in my work, in my relationships, have stemmed from that crossing of like recognition of like, I don't know what I'm doing. And I want to be useful. And I just ask for my path to be created. And every single thing that has good in my life has come from that experience. So I live that value, and I try really hard to actually incorporate it into my work as well. And so we prayed over the medicines, and one of the things, oops, sorry, I might have gotten too ahead because it wasn't responding. So I don't know. Anyway, and it was a really effective methodology. It was a really effective approach. And we, as community, one of the beautiful things about COVID, and it's really hard to imagine a beautiful thing emerging from COVID. I know personally, I was sick with COVID. I was in the hospital for a week. I didn't think I was going to see my children again. It was a really, really challenging time for me. Again, didn't know what I was going to do. So I prayed at the hospital. I asked somebody to bring me medicines, and I prayed over them and asked for help. And, I started getting better on the 4th day, which is really symbolic too, I think, in some ways. Yeah. 4 and 7, I think, are really sacred numbers, right? Anyway, the beauty of the experience of going through that as a community was that it really helped us to sort of like show each other and show the world how good of a job we can do of taking care of one another in crisis. And when we set aside ideological differences, and we just sort of like, follow that original instruction of being a good relative, showing up and taking care of one another, and just being a good relative, how transformative that can be for our communities and our families and for ourselves. So that was a beautiful experience that I learned from that. One day I'm going to write a book. I'm not really sure when, but I have some other things I'm taking care of at the moment. So I have 2 children who are in hockey, by the way, high school hockey. And do you have children that play hockey? Yeah, like it's all consuming. There's like nothing else between October and the end of March. There's nothing else that you can do in your life than the bare minimum and hockey, because it just is completely consuming. And so they have 2 years of high school left, and I cannot wait. These are the programs that we have at NACC, which are, behavioral health, dental, spiritual care, and holistic medicine. So we do, we have 3 women and 2 men who have been trained in their traditional medicines and their traditional ways of healing. They do ceremony back home. They've, been taught by their elders, who were taught by their elders, who were taught by their elders, like how to do some of this work. And they work in our clinic, and they work across like the medical clinic, the behavioral health clinic. We have a Suboxone medication administration clinic that we opened up in the last couple of years. And we have 2 people in that just meet with people who are struggling with addiction and mental health issues. And we offer them traditional ways to complement and support the Western interventions. And it's been a really beautiful thing to watch that program grow. It's one of the a primary way that a lot of people in our community that are sort of mistrustful of large systems like healthcare and prisons, and they have a real good reason to be mistrustful of those institutions. They haven't been treated very well by those institutions a lot of the time, but it's a door that they can walk through, and they can meet with somebody that is not part of that sort of larger structure, and they build a relationship with them, and they meet with them, and it allows them to sort of access healthcare and wellness and support from a structure that's that they recognize that it's been part of their whole life, right? And it builds a relationship, and then they build some trust, and then they start to do things like, oh, well, maybe I should see the dentist because I haven't seen the dentist in 5 years, or I should see a primary care provider because I haven't attended to my diabetes for 3 years. Or so it's a really good program, and it supports a lot of the more critically important, from their lens, the more critical part of their life, which is like their physical health and well-being is important, obviously, but it always takes a backseat to other things, like, right. Kind of like me, like, and like I have children, I got to get them back and forth to school and all these other things, like, the busy cadence of their lives. And if they're poor and they have like multiple barriers, their health takes a backseat to a lot of these other things that they feel like they have to take care of. And so giving them a space and place where they can enter the clinic, where no one's going to say like, where have you been for the last 5 years? Your diabetes is completely out of control. And, shame them and barrage them with all kinds of questions. It's a door they can walk through where they feel comfortable. They know ceremony. They understand it. It's familiar to them and they recognize it. And they might be more interested in spiritual work at that point in their lives, right? But we work really hard on the integration as well, though. So it's integrated throughout the clinic. We work a lot. We do a lot of harm reduction services and peer recovery services, and all the kinds of work out in the community that help to reduce the impact of the social barriers that prevent people from being able to access care and to benefit from it. So about 3 or 4 years ago, you might have remembered the Wall of Forgotten Natives was happening in South Minneapolis. That was about 4 blocks from, here's one of our elders in residence. She's really well known in the community. This is the day we rolled out the vaccines, and we had all of these elders come, and some of them volunteered to let us take their pictures and put them on social media. And she was one of them. And she was one of the ones that prayed over the medicine too. So this is Donna LaChapelle. But we do harm reduction services. And the reason we pivoted to this model of like low barrier care, high access, is because 4 years ago, when the Wall of Forgotten Natives was happening, just 4 blocks east of my clinic, it was the largest encampment of houseless people that Minnesota has ever seen in its history, writ large, and at that time anyway. And the majority of the people living in that encampment were Native Americans. And I had an outreach team that was going out and doing things like syringe services, giving people, helping them pick up dirty needles in the community, those kinds of things, giving them access to wound care, wound analysis, those kinds of things, and just helping them sort of kind of, manage the things that were going on in their lives that were really challenging. And one of the things that they came to me, my outreach team said, like, do you know about this encampment that's 4 blocks to right down here across from the Indian Center from Cook Community University Healthcare Center? And I said, no. And that's because I live in Prior Lake and I drive in from the west. So I never came down Hiawatha or never came down that part of, so I will always come this way, right? One lesson I learned is like, take multiple routes to work, and you're going to learn a whole lot about the places and spaces around you if you just don't take the same path every single day. So thank you, Creator, for that lesson. And I walked through the encampment, and I was like, I literally was like in tears by the time I finished walking that 1 block. I saw people in the encampment that were like people I went to high school with. I saw a niece and an auntie there that were members of my family, my extended family. And it was just heartbreaking. I saw little tiny kids living with their parents in tents, no shoes, just like there was no running water, there was no bathroom. It's just like, it was like the kind of conditions you'd see like in a developing country, or what we would call a third world country back then. And I was like, speechless. I was angry and I was speechless and I was tearful and I was having a whole range of emotions. And so I left and I went back to my clinic and I called the mayor's office and I was like, are you aware of this? Like, this is unconscionable. We need to do something. Like, you are the executive officer of the city. You need to respond to these conditions. And, you know, he had taken my phone calls a lot of other times before about other things, and he was, you know, responsive, and he came and we talked as a community about how to respond to that. And I think we came up with some really good solutions. We have behavioral health services, a whole range of behavioral health services that we provide to our community. And those, our chemical health services and our behavioral health services and our cultural healing services have significantly expanded since the Wall of Forgotten Natives, because it was a critical area of need in our community. It was like a defining moment in some of our growth and development as an organization and a healthcare center, because we saw in our, like, outside our front door, we saw the critical need for more of this work, right? There's a lot of places we could go and get, like, you know, dental care, perhaps, maybe. There's a lot of places you can go and get, like, you know, a Band-Aid for your boo-boo and a few other, like, all the things that other places in clinics do that are really important. But nobody in our community was really doing this kind of work, which was, you know, at the moment, at that point in time, and actually still to some extent today, is so critical. It's life-saving work, right? We made an intentional decision back then to, across our clinic, these are just our services, which, you know, you can read on the website, actually, quite frankly. And it's like what a clinic does: medical care, some counseling, and some dental work. And these are all things you can get at any clinic. But I really believe that the heart of our clinic is the way in which we do the work, which is, we don't care if you have money or health insurance. We don't care if you are houseless or live in a big mansion. We don't care. Like that's not what we're here for. We treat every person who walks through the front door as a relative and deserving of our time and our attention and our administrations, you know, are, like, you know, tending to, regardless of who they are, because that is what Creator put us here to do, is to be a good relative to each other and take care of one another. Now, I have had to really help our staff understand, like, well, you know, taking care of each other doesn't mean like you let them just walk all over you, right? Like, that's not, you know, Creator didn't send us here and said, like, be a doormat. Creator said, like, be a good relative. And what do good relatives do? Good relatives set boundaries, right? And say, hey, like, if we're going to have a relationship, here's the boundaries. This is the playing field, right? And here are the rules of being on that playing field. We're going to treat each other with respect. We're going to listen to one another. We're going to ask questions. We're going to challenge each other at times, right? Anybody been in a marriage long-term? Does it sound a lot like a marriage, right? It's like a successful one anyway, right? So I think of the same, like, I don't think like these things are really all that, you know, unique or secret. They're just like, these are basic human principles of interaction, right? Be good to one another. You know, it's like the golden rule, right? Treat people how you would want to be treated. And if you lead with that, your relationships will be different. And so I really tried to cultivate a clinic and a space and a team that approaches that work. So low barrier, you don't need to, you know, in fact, if you come to us with no place to live, no shoes, no food, no money, no health insurance, when you leave the clinic, you're going to have health insurance, because we focus a lot on that, getting people a health insurance act. You come to our clinic and you don't have health insurance, we're going to be like, after you're done with your appointment, we're going to encourage you, not make you, but encourage you to stay for 30 minutes and work with a navigator to enroll in insurance. Why? Because people who have insurance go to seek healthcare, right? And so changing the health of the community, one person at a time or collectively, is about getting them enrolled in the things that are going to actually amplify their health and their well-being, including health insurance. If they don't have shoes, they're going to leave with a pair of shoes. If they don't have a house to live in and they're houseless, they're going to leave with a tent and a package of things, a sleeping bag and other things that they need so that they can be protected from the elements. And they'll also get a housing referral, and they'll also get a few other things, right? So our approach to healthcare is, deeply spiritual, I think. And people give me a lot of credit for creating this, but I don't, this is not my, I think I told you, I started with prayer, right? I asked Creator, what do I do? And somehow the message comes out. And what I've been really privileged and honored to do with this clinic is to orientate it to function like big healthcare does, right? Where you're a patient identification number, and I've been in healthcare. I've been in big, large health systems where they talk about patients as the diagnosis that they are. Oh, the diabetic in room 9. I was and I worked really, really hard with my team. Just we're not going to talk about people that way. We're just not. And it has really, really changed. This thing's not working, but it's okay. Anyway. So I already talked about some of these services. We have a intensive outpatient treatment program and a medication-assisted treatment program that we actually started in relationship with Red Lake. So we have a partnership with Red Lake Nation. They built a brand new building at the end of Franklin, well, not at the end of the American Indian Cultural Corridor on Cedar Avenue and Franklin. It's a beautiful new building. They have a clinic on the bottom. We put an intensive outpatient treatment program in there, and then we built a medication-assisted treatment program that operates out of our clinic. It's a partnership model. Our patients, our relatives go back and forth between the two clinics. We do a lot of work around care coordination. If you can imagine people who are really poor, who don't have a lot of access to services and a lot of resources, they need, and they don't understand it big. They get lost in places like Hennepin Health, so they don't go. We make referrals all the time to Hennepin Health or to these big health systems, and half of them don't go because they don't know how to, any of you ever gone to Hennepin Healthcare and try to go from the green building to the red building? It's oh my God. It's it's like 8 ET days. You have to have a pebble, a bunch of Skittles to follow to figure out your way. Right. And so we focus a lot on just helping people to navigate those crazy spaces. So we have this big, huge staff that healthcare doesn't pay for. So we have to do things like raise money and write grants and do all this other stuff. And we do it because they're not going to go, they won't go to the Hennepin Health Care for those x-rays or for this diagnostic this or that, right? Or a line or whatever. So we have navigators who help them figure out how to move through those big systems and then come back to us for their primary care. And it's been a big investment of time and energy and money, but it's really beginning to change the outcomes of some of our most sickest patients. And so my job as executive officer is to do things like come and talk to you, but also to the Senate and to the legislature and say, this is what you need to fund. You need to create Medicaid should be paying for this as well, because these are called enabling services, right? It enables people to actually crack open a really confusing system that doesn't make a lot of sense to them and make it understandable to them so that they can consume the services, benefit from them, and move through them in a logistical way that makes sense to them, not healthcare systems, but to them, right? And so we've done a lot of that work in our clinic. And we have patient navigators across all of these clinic centers, like in our dosing program and our intensive outpatient program. At any point in time, we've worked really hard to create a one-door model, which is our no wrong door model, really. So it's it doesn't matter which door you come in. If you come through dental, you're going to eventually end up someplace because you possibly will get referred someplace else because Our patient navigators meet with patients and they talk to them about the things that they need. And then they're like, oh, you need housing? We're going to connect you with a housing coordinator over here. Let's walk over there and talk to them now and see if we can get you on the schedule, kind of thing. So we've done that job because we recognize that in order to do holistic healthcare, which is really what we're trying to do, and client-centered, not hospital-centered or not healthcare-centered. That seems redundant, but you get what I mean. We're not trying to do what the clinic makes sense for the clinic. We're trying to do what makes sense for the people who come in and see us. So we worked really hard to do that. So we have a big outreach team, a big harm reduction team. They go out every single night. They're getting people from the community who are struggling with substance abuse. They have many, many people in the community that actually go with them and walk the streets, pick up needles, get rid of them so that our children and our people in our community can walk on the streets and not be worried about that. They talk to them about, safer injection and safer consumption, those kinds of things, so that they don't end up with really horrible wounds on their arms and other parts of their body that then turn sepsis and they end up in the hospital. Do a lot of stuff that helps people to take care of the things that they're dealing with right now. And the foundation of our approach is build a relationship, build trust, take care of them in an authentic way. And when they are ready for something bigger, like treatment or inpatient treatment or outpatient treatment or some other model of care, they're going to walk into that space because you've taken the time to build a relationship. So our model of care is build a relationship first before you ask them to walk across a 10,000 mile bridge. They need to be our patients, our relatives. Everybody really does need this. They need to trust that somebody's going to walk alongside them. And so we do a lot of that work in our clinic. And is it a lot of work? Yes, it's a lot of work. And it's expensive. And, but it is fundamentally, it's soul work, it's like, it feeds me that I get to do this work. We are starting a capital campaign. It's called the We Look in All Directions campaign. We came up with that name, and there's actually an Ojibwe and Dakota name, which is too hard for me to say, so I'm not even going to say it because it's like a really long word. Any of you know ever seen Ojibwe? If you drive up and down the corridor, you'll see like Ojibwe names on buildings, because a lot of our programs, we've been able to do that. And they're like really long. They have lots of words that have double vowels in it. And it's a specific way that you're supposed to say, like, it's not a ah sound, like an a sound. If you see the double a, it's a ah, the ah. So the enunciation of it is really challenging. So I don't even try. But it basically boils down to that we look in all directions. And when we're trying to think through, like, what are we going to name our campaign, we talked to some of our spiritual people and our elders, and we said, like, what's a good name that will sort of like help us people to understand who we are and what we do, right? And explaining like all the stuff I talked to you about. They're like, well, it's really like, let's call it this, the Ojibwe, and that means like, we don't just look here, we look all over the place. We look for medicines everywhere. We look in all directions for the thing that's going to help you. Right. And so then we're like, I like that. We're going to go with that. So that's the name of our campaign, our building campaign. It's really part of an expansion model. So over the last 6 years, we've tripled in size, actually. So when I got to the clinic in 2016, we had 42 employees. Today, we have 110. I was the 43rd employee in 2016 on December 16th, oddly enough. And now we have 110, and we went from, a $3.5 to $4 million operating budget, to now we have about a $12 million budget. Because we've expanded so many of our programs and so much of our work. But the one thing we're running out of is space to do it all in, right? So over the last 3 or 4 years, when we've expanded programs, we've had to put a program across the street or put a program down the street or across the plaza. We had 3 or 4 things in the building that Maria's is at. And we were blessed by a gift from the legislature 2 years ago, a $3 million cash award to buy the building that we were operating in. Remember how I said that the COVID-19 was a blessing? One of the reasons we were able to do that was because of COVID-19. So the Dollar Tree closed down, they moved out, and the building sat empty for a year. And the people who own the building were panicking. They're like, nobody wants to rent this building like that. And so I said, and they came to me and they said, well, you want to rent this space? And I said, I don't want to rent the building, I want to buy it. So I'm not going to dump $8 or $9 million into fixing this place up if I don't own it. And I said a prayer that day when I went to that meeting with those owners, and they were like, okay, we can do that. And so it was a big, huge thing for us. We said, okay, now that we own this building, we're landowners now. And now we can do a whole lot more than we can as renters, right? So we were like, okay, we launched a campaign to build a new health center, 2 stories, because we're out of space. And then once we did that, it was a really simple process to jump to well, if we're building a new building, we should really put housing above it, because so many of our relatives, a lot of the relatives we serve are houseless. So let's do that piece too. And so a year ago, almost to the day, we pivoted and we said, okay, we're going to build 4 floors of housing above our new clinic. And it's all going to be culturally centered, spiritual care. There's going to be medicine gardens in it. And we're going to do our part to take better care of our relatives. And so you thought healthcare was expensive. Building a building is really expensive. Jesus, good Lord. I was like, oh my God, how am I going to do this? So, but what do you think I did when I launched the campaign? I prayed. I said, Creator, I don't know how we're going to accomplish this, but just cut our path. Our relatives need this. Cut our path and allow me to be a servant. Allow me to be, use me in the way that I need to be used so that I can do this work and our relatives can benefit from it. And we've been doing it for about a year. And there's some literature over there on our capital campaign. And, the clinic itself has raised almost all of the money. Now our housing partners, they're a little bit behind us, but I think we're going to close the gap this year, probably, hopefully we have a bill in the legislature right now that's being heard. It was introduced last Monday, so we'll see. But these things will come to fruition because I believe in the power of prayer, and I believe in the power of creation, and I believe when we treat one another well and we take care of one another, Creator God, Allah, whatever you believe in, reciprocates. That's what the nature of relationships are. And so here's what the new building is going to look like. We have a plaza on the top. The clinic will be on the whole bottom of the floor. Second floor will be half of the bottom floor. But there's a little space there where we'll be able to gather outdoors, do stuff outdoors, both as clinic staff, and then we'll share that space also with our the people that live in the clinic. It's multifamily housing, low income. About 60% of it is, 50%. I don't even know what these words mean. These acronyms mean. AMDI, which is affordable. Yeah. Anyway, I'm learning a lot doing this project. I never thought I would learn anything about new market tax credits, anything about low-income housing tax credits, nothing about housing ever. And I'm like, it is everything. It's a lot like raising kids. You have this idea about when I was a brand new father at 44, I had this idea. I was like, okay, I didn't know how I was going to get those either because I'm a gay man and I didn't have anybody to help me produce them. And so I was like, we went out on the beach, and I made out a prayer, and I was like, oh, just give me a family. I want a family. I've wanted a family since I could remember. It was the first thing I ever wanted. And we made a prayer, and 2 weeks after we made that prayer on the beach in Nia Bay, on the coast of Washington, which is where we were living at the time. 2 weeks later, we got a phone call from my partner's grandma. And his cousin was pregnant with twin boys and wanted to adopt them to somebody in the family because she couldn't take care of them. She already had 2 older children. And I was like, oh, 2 of them at the same time. Well, I wanted to, but okay, all right, then we'd be done, right? That's what I thought in my head, like completely unaware of what it actually takes to raise human beings, right? Which is odd because I'm a child psychologist. So, and all that stuff in that book, by the way, it's all theoretical, right? I was like, and then I read that book, what to expect when you're expecting. I tell everybody who's like a pregnant person, like, don't read that book. It's going to make you crazy. You'll be completely crazy. You'll be anticipating every possible thing that can go wrong. Like, why would you want that kind of stress as a new mother or a new father? Don't read the book. Talk to creator, do the things, these little spirits are coming into your life. Do everything you can to take care of yourself so that you can be a good receiver of them. And that's been a good lesson. So when I didn't know what I was going to do to build this thing or how to make it happen or create it, I was like, creator, please help me here. I don't know what I'm going to do. And I have a most amazing team. I have a really wonderful team of people who are helping me raise the funds. And I have a really amazing team of people who provide care to our relatives who have adopted this way of providing care. And they go out every single day and they do it. And it's just a beautiful thing to watch. And I happen to think that I'm the most blessed man on earth. I've been really blessed. And I've come a long way from the boy that was across the street 40 years ago, 50 years ago. Oh, yeah, that's me. And you want to try and say some Ojibwe and Dakota words? There's some right there.
Say it again.
You want to say some Ojibwe or Dakota words?
Well,
They all mean thank you. Pidama Miigwech.
I learned was Miigwech.
Yeah.
I don't know what the other one is, but so we can say that again, Miigwech.
And then
Miigwech. Thank you means
thank you. I really appreciate that, the invitation.
Oh, I'm so glad you were here, and I'm so sorry we didn't have time for questions. I wasn't very good at monitoring the time.
It's okay.
Sorry.
I'm a big talk. I like.
It was fascinating. I'm so pleased with
Ashley should have told you, like, I'm a rambler, like, just she's my operation manager, and she does a really good job of keeping that track. So she had been here. Like, you should have taken the invitation and been here.
But this was fascinating, and your work it's God's work, but I don't know what else to say. It's God's work. So, but no need to rush off. We have church at 11, but if somebody wants to stay and ask you questions,
Yeah.
okay. And then I have to tell you,
To God, he's willing to let me stay.
and you can pick up a brochure about the campaign on the way out if you wish. And I need to say that next week, of course, we have another forum. Reverend Dr. Rachel Keefe, pastor of the Living Table United Church of Christ in Minneapolis. She is the author of a book, The Life-Saving Church, Faith Communities and Suicide Prevention. And she's helping churches work on prevention of suicide. So that's next week. Thank you so much. And Miigwech.
And I think my contact information is somewhere in one of those documents or somewhere, but you can always email me. You can always do any of you like